Thank you, David. Thank you to everyone that's still here on the home stretch. I'm really excited to be talking to you. Let me just make sure that I can move the slide here. No. This is what I say to my students, just do it for me. Okay, thank you. So first, let me just acknowledge Don Milton. It's actually Don's vision, along with our funding from Balvey at the University of Maryland, to really take a deep dive into just the best way to communicate about GUV. I've also got to acknowledge Dr. Cynthia Bauer, who's the director of the Horowitz Center for Health Literacy at the University of Maryland School of Public Health. So we're going to talk a little bit about health literacy, and I'm going to stretch your brain in a slightly different way than your brains have been stretched for the past 3 days. So the context here, of course, is just how incredibly important it is that the messaging, that we get the messaging right, and that the messaging do what it can do, the best it can do. I like the idea of putting this in the context of how important clean indoor air is, so that GUV is part of that overall message and part of that overall important topic. And so I just bring up a few examples of things that didn't go quite as well as they could have or should have, especially for someone who's in public health. So I'm not a businesswoman and I'm not a marketer. So what I'm going to be talking to you about today is really about public health messaging. And we don't have such a great reputation, given one of the biggest challenges of our public health careers, in how we messaged during the pandemic, in my humble opinion. First of all, masks worked. And I'm not sure that that message got out, certainly not as early as it needed to. Also, vaccinations worked and got sort of a bad rap by using the term breakthrough, as opposed to saving lives, less severe infection, reducing deaths. Of course, in our world, it was incredibly problematic that we were not getting any messaging around the probable airborne route for infection. And particularly for me, in the role that I was playing, I thought, why not just assume that until proven otherwise? And that wasn't how that was approached. And then, of course, I thought early on there was just pretty much silence on the role of ventilation, filtration, and GUV. So I want to talk for a few minutes about the myth of the lay public. So ostensibly, that's what we're doing, is we're generating formative research, because it's really not out there, it really hasn't been done yet, on the best way to communicate with the lay public. And these are these people. They're not a monolithic group. It's not an organism. There's a lot of different parts to the lay public, including highly trained infection disease control professionals in hospitals who are, have high science literacy, high health literacy, and still are a challenge as far as communication around the importance of indoor air and also germicidal UV. So I'll leave that at that. We're going to get into it a little bit more. So as I was listening to especially the manufacturers panel this morning, and I attended the meeting last week in Atlanta, I talked to people and people talked about their stories. How do you connect to UV? How did you decide that GUV was it? How did you decide that this was an important technology? And several of the people in the room last week talked about very personal experiences around relatives, close relatives that succumbed to healthcare associated infections. So I challenge you to think about those stories and to even think about maybe in your own self why you're an advocate, if you will, of clean indoor air and GUV in particular. In my case, I'm a relative newcomer to GUV, so I analyzed my own story. I don't think it's particularly riveting. It's not a cliffhanger, but in fact, I had retired in the middle of the pandemic. I wasn't vaccinated, and I'm trained as a nurse. I wanted to do something. My training's in public health, but I was finished with what I was doing. Totally retired. And I got a call from Don Milton, and I thought, well, this is nice. You know, I really would like to do a little something. Maybe I'll teach or go over to the School of Public Health. That sounds like a great idea. Except for that, what he wanted me to do was to dust off my clinical skills and assist with the human subjects, all of whom were infected with SARS-CoV-2, highly infectious, and swab their noses and draw their blood. And I was like, yeah, I don't know about that. But, you know, Don is part of my tribe. I didn't know him. I didn't know very well. I had friends that knew him. He had a great reputation. Of course, he had tremendous scientific credibility. He was also an occupational medicine person, as am I. But he did say something that really convinced me, and that is, you know, you'll be working in this room and you'll have all the PPE you need. And then we've got this engineering control, this germicidal UV. And I thought, well, finally, somebody's applying engineering controls to this pandemic. And I thought that really worked for me. And I felt like it was an extra layer of protection. And I signed up, and the rest is history. Fast forward. Now I have found other things to do within Don Milton's group. And now I'm running the GUV Public Acceptance Research Project. And this is our design. This is very much a formative research project. This is very rarely done. It's difficult to do. It's often not funded to look into exactly the best ways to communicate. Of course, I'm taking a deep dive into multiple literatures, but also one of the things that we decided to do while we were waiting for our human subjects approval was to look at what's out there on the web and do kind of a critical analysis of the information that's available to the public right now on the web. The rest of the design is a community-based participatory research approach. I have experience with this method from other occupational health research that I've done in my past. We are identifying communities from whom we are getting input. We will eventually be doing key informant interviews and focus groups stratified by what I'm calling literacy and culture. It's practically going to be, different parts of the state. We're going to different geographies, different communities. And ultimately, there's going to be message formulation and message testing. So we're going to be using a health and science literacy lens. And one of the most important things about health literacy is that it predicts health outcomes. So that's critical. And one of the reasons that low socioeconomic status populations have such poor health outcomes, it is suggested, may be because of low health literacy. And this concept is not just about understanding what you're hearing. The whole concept about health literacy, when you're really doing health literacy correctly, you're talking about access to information that's accurate and also that people can use to do what they need to do. So they're using it to make decisions, they're using it to take action. And so it's very much of an equity framework. And basically, you're not really doing health literacy if you're only selecting those populations who are easy to talk to and understanding what you're saying. You really have to try hard to get to broad swaths of diverse communities. One of the things that you can do when you're talking to a target audience is assess people's health literacy, which is fairly time-consuming, and there are validated tools out there. But looking at this graph, the other thing you can do is just assume low health literacy and low science literacy. And that's probably the approach that we're going to take, given that 88% of people in the United States, by and large, are below proficient. And so this is kind of the other shocker when it comes to trying to communicate about complex health and scientific concepts is you really have to drill it down to language and words that people can understand. And it's shockingly difficult, especially if you operate in the world that you all are operating in, especially like we have for the last 3 days. So our formative research questions are these. How clear are current GUV informational websites? I'll talk about that today. Later, we'll be moving on to what do people actually know about GUV and how does this knowledge vary by cultural and community characteristics? Where do people get information and why, and whom do they trust? And how does that vary? And what informational tools really help people make decisions? Which tools will empower diverse audiences for making those personal, maybe not so many personal decisions and family decisions, but certainly community level decisions about using GUV and entering spaces that have GUV there. So basically the design of this is to start off with the web content analysis. The public acceptance qualitative study is going to involve key informant interviews, focus groups, again, stratified by health literacy indicators. And we also have a GUV field installation case study arm to this that is also going to have, and that has already started, key informant interviews and focus groups. So the web content analysis was a project that I started thinking about, and I had initially just one student researcher, and I kind of dispatched him to scrub the web. I gave him a few terms, and he found a few more, and he just started pulling up website after website to enter into this project so we could decide what to do about it. And ultimately, we decided to categorize the websites around sort of the typical .gov, .com, .org, .edu. And I wanted to focus initially on the public health websites. And initially, I wanted to have students not have a lot of information about GUV. I wanted them to be similar to the public. So I told them to go bring up these public health websites and use this tool called the Clear Communication Index. It was developed actually at the Centers for Disease Control, and I provided some training about that. Initially, not a lot of training. I sort of gave the user manual to the students. The reason I have this website to the right, which is the National Center for Environmental Health's website, is because one of the students came up to me and said, Dr. McPhaul, so I scored this website really, really high, but it's really not about UVC. And I thought, okay, so we have a little bit of a problem here. And this one, of course, is mostly about sunlight. And that was sort of the problem with a lot of these websites. They do mention UVC. So we kind of regrouped, we retrained everybody. We said you have to be looking for either germicidal UV or UVC. And these were the 6 websites that we went with. I, being an occupational health person, really wanted to understand if OSHA was helping working populations with their questions about GUV. The students found the National Center for Environmental Health. We decided to do WHO, the EPA, and the FDA, and the students also found this Centers for Disease Control website, and they didn't find the NIOSH website, so we didn't do the NIOSH website. Sorry. It didn't come up on the search terms. So anyway, a note about the Clear Communication Index. We're gonna, basically, it's a standardized way of scoring messages, and it's not really made for this use. It's actually made for the internal agency people to meet the requirements of the federal plain language law, right? So the government in the US, the government agencies are actually obligated to communicate to the public in language that the public can understand. And the Centers for Disease Control came up with the Clear Communication Index. And this is what the agencies are supposed to use, at least the CDC, as they're developing materials. And then these materials need to be scored before they can be vetted and released to the public. So initially, before I had kind of called the students back in to focus on GUV, this was kind of the score of the 6 students that were scoring. And basically the scores kind of varied, but they more or less went together. I do think that the students were hesitant to criticize the websites and hesitant to criticize the government. But there was some variability, and the CDC UVGI website is the one up there that you see is scoring pretty high. And this was the period of time when the NCHS, the National Center for Environmental Health Sunlight website also scored pretty high. And then we sort of regrouped and tightened up our criterion, retrained all the students. And at this point, the black line you see is the score of 90. So a 90 is considered a passing score with the Clear Communication Index. And the CDC UVGI website did hit the 90. The NCHS kind of dropped off. So basically the scores are pretty low. OSHA probably being the lowest. They had both a letter of interpretation, and we chose their non-ionizing radiation page to score. The FDA was also pretty low. The EPA was kind of up there in the maybe better than average, but not hitting the passing score. And then this just represents the difference between getting the students to be a little more focused on GUV and particularly UVC. So the highest scoring website, what is UVGI? That's put out by the CDC. I wanted to show you a little bit about this. You've already seen this graphic once. I had actually scored this website in the training with the students, and my score was really quite low. I felt like there was a lot of technical jargon. I felt like that the text was very dense. I felt like it was a little bit difficult to understand. And the message, if you will, seemed to be about installing upper room UV systems with a competent person, which I certainly don't disagree with, but it was incredibly vague. And the whole thing was a little bit out of context. So that was, to me, that's what the main message seemed to be. The next round we are going to go with, and the students have not done this yet, except for the one initial student who was finding all the websites. This was the highest scoring website of the non-governmental websites that my initial student found. And when I realized that, I thought, oh, well, let me put this up here. And of course, this is the Columbia website, which has followed an awful lot of the communication principles that are outlined in the Clear Communication Index. Most notably having good graphics to support the text, having the text be chunked and manageable and understandable, ways, and also basically trying to help people with numbers and help people with what they should be doing. So I think there's also some improvements here, especially if you look at the Clear Communication Index, but it scored above 90, so it definitely made the grade. We're also trying to do a deep dive into the literature. I'm not going to go through with a full literature review now, but I kind of feel like so much went wrong during the pandemic that I'm interested in studies that analyzed what were the lessons that were learned particularly around public health messaging. And this study was a review that went all the way back to 2005. But one of the key findings of this that really caught my attention was that during the pandemic, people trusted total strangers on social media. Now, I think if you drill down on that and understand that, and this is something I have to look more into, they may have been total strangers, but they must have been some sort of culturally connected in some sort of community. So they said that that was kind of the first time they'd ever seen anything like that. And they kind of made the point that traditional media is much better monitored, much better regulated, and that at social media, it's completely unregulated. So this is still a frontier that people are trying to understand. In contrast, this study by Albrecht talked about an activity of a group of female scientists that got bigger and bigger and bigger. And they basically referred people who had questions to each other until they were networking and answering questions of basically people that they knew, like their friends. So they kind of had a trusted community, but it got bigger and bigger and bigger, and they put it all online. And so as they moved through the pandemic, and now they've moved on to other issues, they became a trusted, credible source for a variety of people, many hundreds of thousands of followers. And this paper talks about their lessons learned, which included fostering trust. So initially, as I said, this organization started just referring friends to a friend. Oh, I'm sure my friend will answer that question for you. She works for X organization. They also took on the infodemic on its own turf. So they felt very strongly that they put all their information up on social media, made it available to everyone, but they also sort of fought misinformation and disinformation out there on the web as well. And they had some other lessons around these very specifically crafted messages that they created for individuals. They continued to answer individual questions, and they still do. And by making it painless, I think what they mean by that is sort of the principles in the Clear Communication Index. You need to be able to digest what you hear and act on it. So when we talk a little bit about who should be providing messages, I think this is something that's also evolving in the past, and this is a Gallup poll. The Gallup poll happens every single year. This one happens to be comparing an Asian groups of populations in Asia with the rest of the world, but doctors and nurses have always scored well above anyone else as far as trusted messengers around medical and health information. But that appears to be changing. And there were populations, particularly those people that don't go to the doctor and don't trust the medical center, the medical system, that got information in other ways. And so one of those ways, which is depicted here, is through beauty salons and barbers, which was an effort that came out of one of our colleagues at the University of Maryland. And I have since read a paper that talked about the role of librarians, community librarians, in disseminating public health information. So there's a couple of other things going on that are certainly bigger than me and bigger than this issue and bigger than what we're going to be able to address. But fortunately, the Nobel Prize organization and the national academies have decided to tackle issues of misinformation and disinformation, specifically around science skepticism. And this is for a variety of reasons. They actually consider this very much of an existential type of threat, and brought together a multidisciplinary group of scientists and others to talk about this. And their concern, of course, are the really, really big issues such as climate change, but I think what has happened during the pandemic was also part of the root of this activity. So we should know that there's kind of also some help out there in terms of combating science skepticism, misinformation, and disinformation. The other animal that we can't really control, it was brought up a little bit this morning, is the media. So I collect articles that I see in the media. This one is basically when the country of Belgium decided to regulate indoor air, and this was written up probably in the Times or something like that. And this was a relative relatively good news story. And I know that many of you have been quoted in the media and communicated in the media, but I think it's not going to be something that we can control. So other people have talked about bad things that have come out of the media, but we just need to understand it. And ultimately, people who are comfortable talking to the media and have good messages and have message training and tested messages should be able to be successful when talking to the media. So to sort of summarize, the specifics around assessing materials that you put out there are these: having a main message and a call to action. Be careful about language. This is not only language that your target audience speaks, but also words that your target audience uses so that your message makes sense to them. There are also issues around design and being able to communicate the state of the science in a credible way. Who are the scientists? So for this reason, this meeting and the documents and the papers and the standards that we're talking about are going to be critical to the communication efforts, because at some point we're going to be able to say things like, this meets the ICFUST standard or whatever that we've been talking about, and that's going to be a critical part of our communication. Those behavioral recommendations are also important to have in there. And when we say numbers and risk, there are very specific ways, if you're going to report numbers or use numbers in communication, that you have to be very careful to make sure that people aren't having to make their own calculations. So I know this is something that will be very relevant to us as we start to look at things like workplace levels and access to information that we want people to know about and understand, and the units that we use. And that's sort of the same with risk too, being able to communicate risk and benefit so that people can weigh them both and make their decisions. So the photo on the left is actually was put up by a diner near us, and they really did not do a bad job considering that they were out there very early. Their headline or their main message is, we're going to make the indoor dining like the outdoors. I liked the way they sort of harnessed state-of-the-art hospital-grade air purification systems. Like somehow what goes on in hospitals is better than the rest of the world, but they're going to do it in restaurants too. And then they go on with very simple graphics to talk about what they've installed. It's all very honest. It's all very accurate. But what I found really kind of odd is that then they had like sort of endorsements or testimony, and it was where you saw this. You saw it on Fox TV or CBS or other media outlets. And so these logos, if you will, or stamps of approval at the bottom are really media outlets, but not so much, the scientific certifications that we hope are really what underpin the technology when it's used. So to summarize, I want to make sure that you got audience, message, and messengers. And the big thing about the audience is, what is their health literacy? And if you don't know, basically go low, because people are not going to understand this immediately with the words that we use, but I don't want to dismiss people's ability to understand. So we're going to define things, and we're going to explain things to people, and ultimately they're going to be able to understand and make decisions. We do need to respect and know our cultural communities. People need to not feel intimidated or dismissed or disrespected. I know we want the message basically to be that it works. This is with respect to GUV, and that it's safe or protective. But the where, when, how, and who are certainly going to be critical with GUV, and that's important information. I'm not suggesting that it be oversimplified or hidden, but it'll have to be explained in words that people can understand. So the issue primarily with messengers is really trust, trust, trust. People are going to basically listen to people that they trust, and that when it comes to going broad and diverse across communities, you really have to have a track record. And this is this is more about trust of diversity, inclusion, and equity, as we sort of abbreviate it. This has to be something that you have a reputation for, basically making sure that everybody has access to actionable information. And so pay attention to cultural community leaders. At least that's what we're going to do. So thank you for your attention. Thank you for inviting me. And I'm certainly happy to answer questions.
Well, thank you so much for a fabulous talk. We do have time for a few questions.
Is Lou still here?
I hope so. He said he would stay.
I'm going to make a non-politically correct statement, and you can correct me if I'm wrong. As a former NIOShan, I feel I can say this. I don't know if you'll be able to. Kate, you mentioned that NIOSH, they didn't find anything on NIOSH. During this COVID thing, NIOSH was micromanaged and everything went through the COVID group. But within that website, it referred back to NIOSH UVGI documents and other things. So it's not that NIOSH wasn't represented, but Ken Mead and Steve Martin essentially wrote all the environmental control stuff that was in those COVID websites. So just to make sure you knew some background information.
Well, no, that's absolutely true. And so that's part of the strategy of the messaging. So the links are there, certainly, to go back to NIOSH. And I certainly knew it was there, but I still felt like I wanted to take a relatively naive group to see what they could find if they were similar to the general public. What is this stuff? Who knows about it? Who's endorsing it? That type of thing. So you have to dig to get down to that NIOSH thing, NIOSH stuff. And then once you get to the document, you have to read a lot.
Hi. In engaging with the public, how do you disentangle education from bias?
I'm not sure that we're actually going to be able to do that. And I'm not sure that we have really the tools to do that. We're certainly not going to be able to reach everybody, but the idea is to try to get to communities that don't view public health the way certainly I do and the way we all look for information. So we are currently trying to find communities and spokespersons that might have handled public health very differently in their communities and also gotten information from very different sources. I mean, we're not there yet. We've sort of started with our GUV installation sites locally, but that's the plan. And to be honest, in a formative sort of qualitative approach, I'm not sure what we're going to find. You know, I just really don't know. And whether we'd be able to distinguish that, I really don't know. Although I will say we're going to ask about educational level, but we're not going to ask about biases.
Kate, everybody's biased. We are. And the best way to recognize bias is to check it against somebody that you trust who doesn't have your bias, like your wife or husband.
Okay, well, one more question, then we need to move on.
This is kind of a multi-pronged question, but we use certain terminology, and I think it hurts us. So even as I looked at your search term, the germicidal UV radiation, and I feel that this has got such a negative connotation that it causes a problem. And then on top of that, you know, we were listening to the EPA earlier. We're in the community, we call our lamps germicidal because that's how they're designated, but that makes it automatically fall afoul of some of the pesticide, you know, the claim part of it. Should we develop new language and and would you think that that would help, or would that make people think that we're trying to be unfair? I just to make it a little bit clear, GE, when they brought out MRI imaging, they made a really big point inside GE, and then they tried to get the community to stop using the word nuclear. You know, so even though that's nuclear magnetic resonance, and every scientist understood that there was nothing that had anything to do with nuclear radiation or anything like that, it was still being misperceived by the public, and they got the public to change, or they got the language to change and call it magnetic resonance imaging. Could we do something similar to that?
Well, I mean, you raise a great point. So I worked with a depleted uranium project back in the 90s, and risk communication back then was well aware of the phenomenon of radiation, raising lots and lots of community fears, almost to a shutdown type of thing. In fact, I mentioned this GUV project to my dentist, who also shut down. She just shut down. She wouldn't listen to me. She didn't want to talk about it. And, the fact that the website that we brought up is UVGI, it says irradiation when you use that acronym. Of the early focus groups we've done, I have heard that germicidal is a frightening term. And so I find that kind of interesting, because I find germicidal reassuring, but then look at my background. I like to think of those germs being dead. But germicidal, either it was complicated or it raised the specter, and I don't really know this, I have to dig deeper, of, something that needed to be killed. So I think those are excellent points. I think that's why this is formative, and this is why it's qualitative, is to try to drill down into those issues. Whether or not the language needs to change, I don't know. There are certain words and terms and acronyms that just become acceptable to people over time, and they may not even remember what they stood for. And I would just put PCR out there. I mean, my own mother will say, I had a screening test, but then I did PCR. I don't think she knows what PCR stands for, but the whole country knows about PCR at this point. It's just a word at this point.
I think we need to wrap up, and thank you so much.